Hello, everyone, and welcome to ADA's professional webinar with Dr. Treanor, Optimizing Exposure Therapy. Thank you, everyone, for joining us. Just a quick rundown of some technical guidance. This webinar is being recorded and will be available on demand for all of our live viewers. Closed captioning and translation are available through Zoom, so you can take advantage of that in your Zoom functionality. For those who have applied for CE credit, you will receive an email after this session with information on how to receive your CEs. You can submit questions at any time via the Q&A feature. We will have a dedicated Q&A time, but Dr. Treanor will keep an eye on them as they go along. I would now like to swiftly introduce our wonderful presenter who will guide us through his presentation today. Dr. Michael Treanor is an assistant project scientist with UCLA and a staff psychologist with the UCLA Child Anxiety and Tic Disorders Program. His research focuses on associative learning processes as a principal mechanism of exposure therapy. He is also the owner of the California Center for Anxiety and Traumatic Stress, a group practice focused on providing high-quality exposure therapy in CBT. Dr. Treanor, thank you so much for being here today. I'm going to hand this off to you.
Thank you so much. Excuse me. Just want to thank the ADAA for having me and everybody for joining. Really excited to be here. As what was mentioned, just want to note a few things. So I've been fortunate to be at UCLA for the past 10 years at the ADRC with Michelle Krass, that I'm sure everybody knows of. Been really grateful to be working with her on research on mechanisms of exposure therapy and writing on those results. I also actively see patients. I've worked for many years at an IOP for veterans with post-traumatic stress disorder at UCLA. I'm currently an attending at one of our OCD clinics where I see some patients, and I also train and supervise others. And I'm also, as mentioned, sort of the owner of a small group practice where we do specialty sort of exposure in CBT for a variety of difficulties. In addition, I offer some consultation through there for people looking to apply associative learning models. So I say all that with the hopes and the humble hopes that I have some of the experience in the research as well as direct clinical work and supervising and training people to make this useful for everybody. We'll try and breeze through some of the things as fast as we can so we have some time for some good quality discussion. Feel free to ask some questions throughout. If I can answer them right away, I will. Otherwise, I might say hold off onto another slide, but we'll also have some dedicated time at the end for questions. And just really looking forward to talking about this. It's a passion of mine and having some fun. So let me share my screen, get started. All right, that's me.
Looks great.
Great. So kind of a broad overview of what we're going to be talking about today, and these points will be interwoven throughout my talk, but basically, there will be some overview of Pavlovian learning, a particular type of associative learning, and some empirical evidence for associative learning processes as mechanisms of exposure treatment. We'll also talk briefly about some of the limitations of that evidence. I really want to be upfront about where we're at. The main purpose of the talk is to focus on foundational strategies for applying this model and conducting exposure from an associative learning standpoint, and to talk about some of the common pitfalls when applying this that I've seen over the years that people have mentioned. I'll give some examples of specific exposures for different types of anxiety disorders, OCD, and PTSD from this model. I assume, and I'm seeing from the chat that, a lot of people probably have a good foundation or some expertise in CBT and exposure therapy. You don't necessarily need that expertise level for our talk. It'll be on a more foundational level, but happy to talk in more detail about some more complex presentations as we go through this. And again, feel free to ask questions, and Sasha will feel free to point out if there's particular questions. Hi, Dirk. Just saw somebody and everybody from Leuven. So now I know some important colleagues are looking at this, and I can get some extra nerves going on. What we won't be able to cover are some more of advanced strategies in applying this model in terms of some things we call deepened extinction and other processes. I won't be able to cover in much detail imaginal exposure. I can try and handle a few questions about that. I'm currently working on a paper about that, and Michelle and I are hoping to submit that soon. And I won't be able to go into tons of detail about limitations of other models of exposure therapy. Talk a little bit about that, but we'll sort of see where we get there. Okay. So by exposure therapy, just to put that out there, I'm just referring to the systematic and repeated confrontation with the stimulus in order to alter an emotional response. And I use this deliberately vague term to mean that, exposure therapy is just what an intervention looks like on the outside and is kind of agnostic to the mechanisms that might be going on. You can use exposure therapy to target a variety of different mechanisms. And we're going to be talking about one particular mechanism here today, or several. It's one of the gold standard treatments for anxiety disorders, OCD, and PTSD. Prior to DSM-5, I could just say anxiety disorders, but now I have to spell everything out. And of course, decades of research support exposure therapy for a range of disorders, and including really severe presentations. So again, I would assume that many people joining us today are proponents or fans, or at least comfortable with exposure therapy, but just to put out or address some questions or concerns some people occasionally have with exposure therapy. There's no real evidence of any iatrogenic effects. Exposure therapy has been used with really severe complex presentations, survivors of political violence and torture, even in active refugee camps, OCD, PTSD, severe anxiety. It's really one of the best things we can do for our patients and our clients when done well. And not really any evidence, even though for decades people still feared doing it with PTSD or severe anxiety disorders that it was going to be harmful. There's no real evidence that it's harmful. It's actually one of the most helpful things we can do. Despite the efficacy, there's a significant portion of patients who fail to achieve remission, high end state function, mild symptom levels. If we're trying to think about how effective CBT and exposure therapy is for the disorders that we treat, there's definitely reason to be optimistic, but also definitely reasons for us to buckle down and trying to figure out how to help this non-insignificant portion of patients who don't achieve the level of symptom remission that we would like. And targeting the particular mechanisms of exposure therapy is one potential avenue to enhance treatment. And that's obviously why we're here today. And I want to say up front, there's ongoing debate regarding the principal mechanisms of exposure therapy. I will talk to you a little bit about why I tend to operate from this standpoint and believe it's an effective standpoint, but by no means do I think it's the only effective way or reason why exposure therapy could work, or is the approach to take with every single presentation that a client comes with. Anybody who is trying to sell you that their theory explains everything and will treat every particular client that you ever see is probably not speaking consistently with the data. We'll just say that. So we'll talk a little bit about some of those, some different models of exposure as we go through this. So we're going to be focusing on an associative learning model. And for those of you familiar with the writing coming out of our group at UCLA, Michelle's group, we originally termed it inhibitory learning approach. We've now sort of revised that for various reasons to call it an inhibitory retrieval model of exposure therapy. And just as a basic starting point for everybody, when I say associative learning, I'm saying it to refer to the process of learning relationships among a variety of different things. Stimuli, context, outcomes, behavior, just the whole sort of way that organisms learn to navigate their environment by learning associations among a variety of factors. Pavlovian learning, on the other hand, is going to refer to a particular type of predictive relationship among stimuli and outcomes, and we're going to talk about that a little bit more. The original models of exposure therapy were based in associative learning theory. So for those of you who know Watson, little Albert, making that poor kid afraid of the white bunny rabbit, is his colleague, Mary Cover Jones, was one of the first people to apply associative learning models of exposure to treatment. Unfortunately, over time, that sort of basis in associative learning got lost during the so-called cognitive revolution. Exposure models shifted to a more information processing and what people have called a habituation model, somewhat due to a misunderstanding, I think, of learning theory, both from the evidence that was available at that time, as well as all the amount of evidence that we'd accrued in the decades since. But there is a good amount of recent research in the that suggests returning to an associative learning model of exposure therapy for specific symptoms. I should mention that. So what is briefly some of the evidence that suggests that associative learning models of exposure are worth considering, or that we should return to thinking along those lines? So one is that individuals with anxiety disorders, panic, social, PTSD, OCD show deficits in associative learning. They show higher reactivity and greater fear to quote unquote safe stimuli, higher fear generalization, a spread of fear from the original stimulus that they were taught to be afraid of to other perceptually and semantically related stimuli. That's sort of a broad spread of fear, which makes sense for those of us who work with patients clinically. And for our point here, and it's important to acknowledge that they also demonstrate slower extinction learning. So for example, it takes longer for an individual with social anxiety to learn that social interactions do not lead to rejection, right? So like after learning that something is dangerous, people with these various threat-related disorders are, whether you say more reluctant to let go of that, a better safe than sorry approach, or just take sort of a longer time, or it's less robust, they show sort of impoverished extinction learning. There's some emerging evidence, though we need much more, that deficits in associative learning predict response to exposure-based therapy in both children and adult samples. Our team here at UCLA is currently submitted another paper that examines that. I will acknowledge that this is an emerging area of research and we need much more evidence demonstrating this, but the evidence that we have thus far is promising, and I think is another key to the puzzle that suggests that associative learning processes are both part of the disorder makeup and are a potential target and mechanism for treatment. Importantly, newer research is showing that exposure therapy is associated with changes in associative learning. A good colleague and friend, Andre Pittig, over in Germany, and their team recently published a paper that perhaps many have seen, looking at, it was a multi-center study looking at exposure therapy for mixed anxiety disorders, mostly panic and social anxiety, I believe. They looked at over 600 patients, over 8,000 exposures, and we won't go into too many of the details, but basically found that increased extinction learning, some of what we're going to talk about in terms of what's called expectancy violation and that sort of expectancy violation change during exposure therapy related to improved outcomes. So individuals who had greater learning in this regard showed better response to treatment. And I think this is one of the more recent and more powerful examples that associative learning processes, and particularly extinction learning, might be a principal mechanism of therapy. For those of you who know, I'll just say there is some evidence that pharmacological agents that target associative learning processes, so D-cycloserine, which is a partial NMDA agonist, which enhances memory consolidation, might augment exposure therapy. I know for those of you familiar with this literature base, I know there's legitimate debate around this because we don't always see these beneficial results. I think there's a variety of reasons for that, not in the least that most people who do exposure therapy don't necessarily do it from an associative learning standpoint. And therefore, if we're not directly targeting those mechanisms, it wouldn't be a surprise that a pharmacological agent doesn't always relate to improved outcome if those mechanisms weren't targeted. But I put it up there to note that there is at least some pharmacological evidence that suggests that targeting associative learning processes through pharmacological agents improve treatment response, and therefore it's indicative that this might also be a mechanism of change. We, of course, I want to say, need more research in this area and more nuanced research, more research showing that associative learning processes predict treatment response, that they act as a particular mechanism of change. My own perspective on the research is that, one, our knowledge base of associative learning processes in terms of the mechanisms, the processes, the molecular substrates of it, the neurobiological substrates, is really deep from decades of research. We know that a lot of people with these disorders have deficits in these processes. And I think there, as I've highlighted, some promising evidence that these are an important target for intervention. And that's one of the main reasons why and also because some alternative models just are wrong, in my opinion, in various ways. So I think this is one of the more promising areas of a potential mechanism of exposure therapy. But again, we need more research to firmly establish it. But we'll continue this talk thinking about, if we are going to apply this model, what would it look like? So associative learning models cover a range of mechanisms. And again, for many of you who are familiar with it, include terms like extinction learning, stimulus discrimination, counter conditioning. Many of them fall under the umbrella of what we call Pavlovian learning. And Pavlovian learning, again, apologies if this is basic for some folks, but I think it's important to talk about it just to make sure we're all on the same page, is all about prediction. So let's take the case of social phobia. In social phobia, social interaction, what we call the conditional stimulus, is thought to lead to rejection, the unconditional stimulus, and that's what produces anxiety or the conditional response. So first, I just want to say for all the learning theory nerds out there and everybody, that it's conditional and unconditional, not conditioned and unconditioned. That's an incorrect translation from Pavlov's early work. So all of you can impress all your friends at the next psychology happy hour and get together, when you can drop some of this knowledge about how many of the field have been using the terms incorrectly for all these years. But to get back to the main point, sort of, this is what Pavlovian learning is, and the main learning process that underlies some of the formation of these threat-related memories and the emotional response to them. So we think of this as a stimulus interaction or association, and SS star interaction, not an stimulus response association. And that's important for what we're going to be talking about and how to do exposure therapy. So in SS star learning, it's that social interactions predict rejection. That's the main association that's in place. In stimulus response learning, it would be that social interactions are associated with anxiety, and that's what maintains the anxious response to social interactions. And we've known for many decades through animal research and human research that this isn't the case, that the reason why anxiety might be present in this circumstance is because there's a particular type of predictive association, which means if you want to alter the emotional response, which is the conditional response, you have to alter that predictive association. And so that's what we're going to target as we think about applying an associative learning or a Pavlovian learning approach to exposure therapy. And this type of learning, whether we're learning to fear something or whether we're learning that something might be safe, proceeds via what we call error correction. And that's a change in this predictive association that's a result of the discrepancy between what is predicted and what actually occurs. So you can think of it, I like to think of it almost like a dial on a knob, that kind of goes up or down depending upon the strength of the predictive association that's present, and changes in that, proceed via decrements, via this error correction. It's not an all or a none switch. It doesn't go on and off. It sort of changes at various rates depending upon this discrepancy. Some important considerations when we're applying associative learning models is that first, and I want to say this clearly, one of the things I often see in the difficulties when people read some of our papers or try and apply this is that they're trying to apply it in the wrong case. Not all symptoms of anxiety disorders, OCD, or PTSD are Pavlovian in nature, not all particular symptoms or presentations. So just as kind of a few key examples, certain distress regarding symmetry-related concerns in OCD and not just right feelings, the components of guilt and shame that might be there in certain presentations of PTSD. If there isn't a predictive association in place, that a particular stimulus is going to predict a particular biologically significant outcome in many cases, as we're going to talk about, then it's not Pavlovian in nature, and therefore trying to use this model really won't fit. So extinction learning is only going to be effective if there's a Pavlovian or predictive association. When that's not the case, that doesn't mean that exposure itself won't be effective or other strategies. Additional strategies might be helpful, cognitive processing therapy for PTSD, mindfulness, other types of approaches to target these additional sort of treatment presentations. And I think this is one of the areas where people get stuck in initially applying the model. I will say that I think, in my opinion and in my experience, many disorders, I would say the majority of presentations have a Pavlovian element that is significant and therefore is worth targeting in treatment. Even when that's the case, so that doesn't mean that when you do that, or when I do that with a patient, that's the only thing I'm ever going to do with them. For many patients I work with, it's the main thing that I focus on in exposure therapy, but there might be, after a good chunk of exposure therapy, I might add additional strategies. We're not going to necessarily talk about that. But I just want to highlight that I'm not saying this is a panacea for every patient that walks in. What I am saying is that for a majority of people with anxiety disorders, OCD, PTSD, that this is a significant consideration and worth thinking about targeting and treatment. Finally, before we go on, I just want to mention a quick note about the term habituation that people for decades have used when describing exposure therapy and why it might be effective or why it might be helpful or sort of what's going on. So technically, when learning theorists and others who study learning and memory processes talk about habituation, habituation is a non-associative process that results in a decrease in response that's not due to sensory or motor fatigue. Okay, I know that's kind of like seems like an overly jargony definition. But when you have a change in response to a predictive stimulus, a conditional stimulus, it's usually due to learning and unlikely to due to habituation. So for example, if you teach somebody to be afraid of a particular image of, like, say, a picture of a face, like every time or a certain percentage of time that that's presented, they receive a shock. And then you repeatedly present that image in the absence of the shock. We know, for a variety of reasons, we can get to this in the discussion, that when the person alters their emotional response to that stimulus, it's because they've learned that that stimulus isn't predictive of the shock anymore, or in certain cases they've learned maybe it's a different stimulus and it's not the same stimulus that was related to shock, which is stimulus discrimination. It's due to a learning process. It's not simply due to habituation. So habituation refers to a particular process. I will also say that habituation is most often to occur with, again, non-associative stimuli. So if you repeatedly shock somebody, eventually they're going to decrease their reactivity to being shocked. So shock is an unconditional response. It doesn't have any other associations or predictive associations. So you can habituate to unconditional stimuli. But our responses to predictive stimuli, to conditional stimuli, which are the majority of things that we work with patients are in therapy, our change in response to those stimuli are usually a result of learning. And so it makes sense to apply theories of learning to how we target that. So habituation refers to a specific mechanism, but our field for decades has sometimes confused this and confounded it simply with anxiety reduction. It's come to mean when somebody habituates that we're sort of saying their fear has reduced, which is not what the term habituation means. So when you say a client has habituated, you're invoking a specific mechanism. If you don't have evidence that that mechanism was being targeted, and for many types of presentations, by definition, habituation is unlikely to be a significant mechanism, then you shouldn't say they habituated. So I really ask everybody, researchers, clinicians, to stop using the term habituation if you're not discussing the exact mechanism. I think this results in too much confusion, and we should just say anxiety reduction, fear reduction, reduction in the conditional response, whatever you like. Reduction in distress, just not habituation. That's my plea to everybody out there. Okay, so kind of basics of Pavlovian learning that we've covered. It's all about prediction. That predictive association is the key association that underlies the emotional reactions to many stimuli that we're working on in therapy. So if we want to target this through exposure therapy, what are sort of the fundamentals of this approach? What does it look like? So the first and one of the most important things is to identify the unconditional stimulus, the feared outcome. So on the next slide, I'll talk a little bit more about this, but I'd like to encourage people applying this model to think about unconditional stimuli, these feared outcomes, as biologically significant stimuli. And so things that should be evolutionarily conserved across time that make sense for survival. So social rejection, it's really bad if you were rejected from the group and excluded, that you're not going to survive very long. Physical illness, violence, something happening to you. We can add the idea of like mental catastrophes, like breaking, snapping, going crazy, loss of behavioral control. So in OCD, people who might worry they might physically harm a loved one, physically harm a child, stab somebody, these types of things, really extreme, foundational, biologically significant events. Conditional responses, like a panic attack, fear and anxiety, are not the unconditional stimulus. Again, in that model, when we're talking about social anxiety, right? Social interactions are thought to lead to rejection, and that's why there's anxiety there. The anxiety is the conditional response. So trying to, if we think about it this way, test out from, if that's the outcome we're trying to violate, whether or not somebody's going to get anxious, they are. And I think one of the ways that this most often gets misapplied is in the treatment of panic disorder. When people often do exposure and with clients, which to some level is great, okay, you did such and such, did you get a panic attack? No. Okay, great, you didn't get a panic attack. You're sort of violating this expectation. If we have time, we can talk more about it, but I would argue that a panic attack is not an unconditional stimulus. It's really what the panic attack is thought to predict, which is having a heart attack, passing out, respiratory arrest, those types of things. That's the unconditional stimulus. So just from a basic standpoint, if you're going to do exposures and the thing you're testing out, the outcome was fear or anxiety, one, most people are going to get afraid and anxious when doing exposures, so you're not really violating anything. The other is that if you, without testing out the right outcome, you're going to leave that association between the stimulus and the outcome intact. If we never target it, it's going to remain intact. That excitatory strength that we think of is going to remain there. And so it's really important to identify the right unconditional stimulus. With clients, other CBT techniques, using a downward arrow technique to try and assist client in identifying the US. What are you worried is going to happen when you have a conversation? I'll get really anxious. And if you're really anxious, what would happen? I won't know what to say. Again, still not at the US yet. And if you don't know what to say, what would happen then? The other person would think I'm stupid. Starting to approach what the US is, but here the therapist sort of now helps them a little bit. I see it sounds like you might be worried they would judge you or reject you. Yes, exactly. So thinking about those core fundamental biologically significant outcomes, that's what, generally speaking, you're looking for. And theory, empirical evidence, and clinical experience, supports or guides us in what those will be. In social anxiety, it's usually some form of social rejection or exclusion. In panic disorder, it's usually some physical or mental catastrophe or, behavioral discontrol. PTSD, there often are some of these, depending upon the nature of the trauma, some other sort of physical or sexual violence, or some of these other fears that might happen. So we kind of know what these foundational fears are, and that's what you're trying to help the client understand is driving some of their anxiety. So you have to identify that. It's really important as you do this, in some instances, to correctly operationalize the US, because this is going to be key to when we're doing exposures. So we often find it helpful to use multiple indicators of US occurrence, because we want to know as we're doing exposures, like did this or did it not happen, right? That's part of the test as we're doing exposure therapy. So for rejection, we can't ever know what the other person is thinking. And we can talk about this when doing exposures for social anxiety, how we navigate that. But we look for more objective indicators of rejection. ending the conversation abruptly, the person scowling, saying something overly negative. And again, if none of these indicators were there, what is it telling us about the likelihood that the US occurred? Other unconditional stimuli are more easily identified. It's pretty clear whether a person passes out, has a heart attack and panic disorder. It might be pretty clear whether somebody develops serious physical illness in certain types of OCD or acts aggressively or harms somebody else in OCD. These things are pretty apparent, but it's still important to identify and operationalize those. And I want to take a moment to clarify and talk about this idea of distress tolerance that I think sometimes people employ when conducting exposure using this standpoint. And it's partly our fault from some of our early writing and how we were writing about it. But I occasionally work with people who might be conducting exposure and say, okay, we're going to test out like how long the patient can tolerate this. Can they do this for 5 minutes or 10 minutes? It's beyond the scope of this particular talk to talk about whether that prediction or that idea is Pavlovian in nature. But what I will say is, regardless of whether somebody can like cope or tolerate it, if there's probably a larger fear that's present, that if you're not targeting it, you're going to keep fear alive. So again, if you're talking with somebody with social anxiety and they're like, well, I could tolerate the conversation for 10 minutes, but you didn't design the exposure to test out whether rejection is going to occur, you're probably going to leave enough of that association left that it's going to still drive fear. So failing to properly identify the US can lead to a preservation of fear or distress. And so we don't ever do exposure really to the idea of like, can the person tolerate distress? I tend to think about that more from like a Bandura self-efficacy standpoint, which is a phenomenal way to do exposure. Occasionally, we do things to test out whether the person will experience intolerable distress. And when we think of intolerable distress, we really think of unable to function in the face of that distress. I've worked with some patients with PTSD who might feel that bringing up the trauma memory or doing certain things will lead to like a shutting down and kind of just collapsing from that distress and inability to like talk or function or walk or do anything afterwards. And that's to me qualifies as a biologically significant event that I could test out. I don't think that's very often the case. I think there's usually in a variety of presentations of panic, social, OCD, PTSD, either a more clearly identifiable US, like I mentioned, or it's probably not Pavlovian in nature. But I basically just want to highlight that doing things to test out how long you could cope with something or whether you can tolerate it is not the correct application of this model, I wouldn't say. So more kind of fundamental. So identifying the US is really important and it's critical. And then you want to identify what we're calling the principal conditional stimulus. And this is a stimulus that is the strongest predictor of the US. Some of this derives from all the great work from friends in Leuven who are doing that. Let's see, just want to look at a question real quick to see if it's something we can address. Somebody asked if that kind of exposure where the association is left intact might inadvertently sensitize or reinforce the US, as in make it worse, not just fail to make it better. I don't think it would necessarily make it worse, and it could still be clinically beneficial for somebody, but I just think you might be leaving kind of a lot of the association sort of left on the table, so to speak, a lot of that predictive association intact. That is just going to allow fear to just persist. I don't know if it would actually make somebody worse unless that fear persisting is a cause for them to be discouraged and to lose motivation for continuing exposure therapy. But great question. No. So let me just, sorry, I had to click through things. Okay. So there we go. So the principal conditional stimulus that's the strongest predictor of the US. There are a variety of reasons we want to focus on this. A lot of it drawn from our friends at Leuven who've done some of this work. But really, when you focus on a stimulus that's the strongest predictor of the US and you get extinction learning to that, you'll probably get some better generalization to some of the other stimuli that might also be predictive, but not the most predictive, but it doesn't really go the other way around. And this doesn't have to mean it's like the most specific stimulus that you're doing. It might be a general class of stimuli. So in social anxiety, it might be initiating and maintaining difficult conversations. For panic disorder, it might be a particular type of physical sensation. And PTSD, I've worked so much with veterans, maybe it might be large crowds. That might be sort of the principal conditional stimulus, but this is the thing that you're going to get the biggest bang for your buck. And so we want to focus as much exposure to this stimulus as possible. And exposure to stimuli that are not conditional stimuli are not going to lead to extinction learning. So certain pictures, images, sometimes context, but they might have clinical utility. And this is another area where I think people often get stuck. So we'll take a client with panic disorder. So not uncommon for somebody with panic disorder to avoid being alone, maybe even being home alone for fear that if they get panic, right, no one will be there to help them. And so although they're distressed by the idea of being home alone, it's unlikely that this directly predicts the feared outcome. It's not as if they think being home alone is going to directly lead to passing out. They think that if they have a panic attack or certain physical sensations while home alone, they might be more likely to pass out. So because being home alone isn't directly related to the feared outcome, doing exposure to that is not going to lead to extinction learning. And therefore, it's not going to be that beneficial. And this is something that I think people have gotten stuck on and might still do exposure to a variety of times. And again, it's another instance of leaving that association intact because we're failing to address it. Same for somebody who says, okay, you're going to go to the mall, a classic panic disorder example, right? Because people might be worried about ease of escape, right? From if they get panic sensations and they go to the mall and they don't get a panic attack. And it's like, great, you did great. You really, again, didn't expose them to the conditional stimulus, which would be the physical sensations. And so there probably isn't going to be the type of learning or the type of benefit that you're really targeting. These additional stimuli are sometimes called, depending upon how they work in the person's associative network, occasion setters, in that they set the occasion for the CS to lead to the US. They're kind of modulatory variables. But we don't, as I've indicated here, think that exposure to those directly are any benefit. And, the basic laboratory research in animals and humans show that that's correct. Similarly, people oftentimes think, and I've seen this in working with younger individuals, that, okay, let's look at a picture of something before exposure to the actual thing. You're really not, most people don't think looking at a picture of a dog is going to lead to being bit by a dog. So you're really not going to get any extinction learning. They might be distressed to look at a picture of a dog because it's more of what we call like a mnemonic referent. It's a reference for their association that they relate to distress, but it's not going to lead to any extinction learning. So you really want to try and find various conditional stimuli, things that directly predict the feared outcome, and expose the person to the strongest predictor. So a key to exposure, and one of the fundamentals, is targeting what we're calling expectancy violation, right? This idea, like we said before, that associative change and associative learning operates via error correction, right? So exposure should be designed to test out if the US is going to occur. And that's the term we use with clients, to not, say expectancy violation or error correction, or kind of be really jargony, right? We want to test out if the negative outcome is going to occur. And theoretically and technically speaking, the greater the discrepancy, the more they're sort of predicting that the bad thing's going to happen. When it doesn't, the more learning that occurs. So we try and maximize that expectancy, which we've talked about in some of our writings, that the US is going to occur, because that's going to be a more powerful exposure. And this is sort of the centerpiece of doing exposure from this standpoint, is that trying to maximize expectancy violation over and over again, and thinking about all the different factors that either enhance or get in the way of expectancy violation. And identifying the US, like we talked about, and the, principal conditional stimuli, stimulus, or variety of conditional stimuli are part of that. You have to know, you have to be able to find the factors that'll lead to the right experiment to design it. And these exposures should be designed to test things out. This doesn't mean that you have to engage in the most difficult exposure at the beginning of therapy. Like, just because I've heard people incorrectly criticize that model by saying like, oh, you have to do the hardest exposure first in order to get the most benefit, or that's what they're advocating. I mean, that's great if you ever get clients who are willing to do kind of an exposure that feels like 100% likely to lead to their feared outcome, and it's the most difficult thing possible. Many people aren't ready to do that right at the beginning, which is completely understandable. So it doesn't mean you have to engage in the most difficult exposure at the beginning of therapy. But it also doesn't mean, sorry, the animation is messed up, but it also doesn't mean that you have to titrate it too much. And just because you titrate exposure doesn't mean you have to approach things in a hierarchical manner. And we have no empirical evidence that fear hierarchies or fear ladders are necessary. You don't have to proceed in a hierarchical manner. The sort of bottom line is, as we operate from this, is we try and maximize expectancy violation as much as possible, as early as possible. And we try to clinically, in a clinically valid way and a compassionate and supportive way, try and gently encourage clients to do, to push themselves as much as possible and to support them doing that. And so that means we push like any exposure therapist does, but we never throw somebody into something that they don't want to do. And we also don't go to the other end where we start like too easy and have to do things in a hierarchical way. It's a little bit more fluid than that. Clinically, we suggest conducting initial exposures with at least an expectancy rating. We kind of use this 0 to 100% scale of how likely an unconditional stimulus feels as a result of doing the exposure. How likely does it feel the negative outcome is going to occur, like in your gut from that anxious part of you, whatever it might be, of at least 60%, although the higher the better. We routinely conduct high expectancy exposures at the start of therapy with patients. I've worked with people at the very start of therapy, and we're doing exposures that feel like 80 or 90% likely. This is, of course, subjective. One person's 80% likely is different from somebody else's. But the lower you are on this scale, and this is just an approximation, the best approximation we have right now, being self-report of how likely something feels, the lower you are, the lower that discrepancy is, the less sort of extinction learning that's going to occur. Towards the end of therapy, of course, we expect and hope some of these expectancy ratings to be lower because of all the exposure they've gotten. But at the beginning, we try and maximize it as much as possible. And again, there's no evidence of iatrogenic effects. I've done this with so many people who are housebound, and it's fine. Just kind of the general strategies and good clinical sense that you would use in being caring and supportive and validating and encouraging while also pushing still apply. Patients are far more resilient than we often think. And I think, we often, do them a disservice by trying to hold back some of these strategies for fear that we're going to damage them. We ask, we encourage, we gently push, we don't force, and we support people along the way. And I think there's no reason to expect that that's going to be harmful to anybody, but I'm sure I'm preaching to the choir here. So expectancy violation at the core. So this brings up the point, what about feared outcomes far in the future? I'm not going to have tons of times to go into this. Our recent paper is something that I hope everybody can take a look at, because that's going to describe this in a little bit more detail. But there are some presentations of anxiety that involve feared outcomes far in the future, making expectancy violation, extinction learning difficult. So for those of you who treat OCD, I'm sure you've seen presentations, with OCD, like let's say touching household cleaners might result in developing cancer years later. It makes it really hard to design an exposure to test that out or to violate that expectancy, right? So the question is, are associative learning models, are the inhibitory retrieval models still effective in these cases? Shorter answer is, we still encourage exposure from this standpoint. More empirical evidence is sort of needed, but let me talk you through a little bit about why it might still be helpful. So Alan Wagner's SOP model of learning and memory, for those of you who are learning theorists are very familiar with this. It's been around for decades. The famous Rescorla-Wagner equation, that's, Wagner as well. And the SOP model talks about, and it's got tons of support, talks about how associations are formed. And associations are formed when stimuli are in different states of activation in attention and in terms of an attentional focus, right? So when you confront a stimulus, it leads to that stimulus becoming active as a source of attention. And when two stimuli are in both those active states, an excitatory association is formed, right? So this is like when we're learning that something is a good predictor of something else. So in terms of fear learning, you see a picture on the screen, then you get shocked, right? You directly experience both of those things. They're both in sort of the A1 activation mode in terms of the SOP model, and sort of an excitatory association was formed. Inhibitory associations are formed when one stimulus is in that active state and the other stimulus is in a less active state of processing, what's called like an A2 level in the model. And this occurs when you retrieve a representation of that stimulus. So when you confront the picture and you're no longer getting shocked, it retrieves a representation of shock, and that difference in levels of activation in the mind, in the brain, sort of lead to a different type of association, an inhibitory association. So that's sort of their description of extinction learning. So when you confront a stimulus and the feared outcome is far in the future, you're still confronting the stimulus, the household cleaners, that brings them into that A1 level of activation. And it retrieves a representation of getting cancer, and that's activated in the A2 level. And so even though you're not getting expectancy violation, some inhibitory learning is accruing. The downside is to this is that, and I know this is getting into the weeds of like learning theory stuff, but that how much learning is dependent upon how many elements, because a stimulus is comprised of all these different elements, how many elements are activated. So again, let's go back to that. Somebody seeing the picture and then they're going to get shocked. Basically, this idea, when something is far in the future, it's going to, I'm going back to how I want to explain it. When something's far in the future, fewer elements are going to be activated in anticipation of that feared outcome than when it's closer in time to when it's actually going to occur. And because fewer elements are activated, there's fewer elements that enter into this inhibitory association. The closer in time to when we expect that bad outcome to happen, the more of its elements are going to get activated and the more that are going to be available for this inhibitory learning. But because it's years in the future, we're not really expecting it to occur. And so there's going to be less kind of co-activation in those two levels, the A1, the A2 levels, and so less inhibitory learning. So what does all this mean? All this means that you might get some extinction learning, you might get some inhibitory learning, but it's going to be less effective than when direct expectancy violation happens, which means you're going to have to do tons more of it. You're going to have to do this over and over again, but you still might get some of it. And so it's maybe worth trying, and we need more research exploring this, but it's also probably acceptable to think about other ways to approach that fear too. I still do exposure to that, to a feared outcome far in the future, partly for this reason. When I do exposure to that, I sort of tell patients in a non-jargony way, it's like, even though we're expecting it way far in the future, our brain kind of encodes the fact that you're safe right here, right now, you're safe tomorrow, you're not getting ill in this example, as some indication that you're okay. And it's not as effective as when we get to learn right away, okay, that feared outcome we were worried about, it didn't actually happen. That's a more powerful way of doing exposure, but we still get some benefit. The downside is we got to do a lot of this for our brain to learn because we're only getting a little benefit. So we're going to work together to do as much of this as possible. That might be one way I describe it to a patient. So still might be something I do, but there's other approaches that are viable as well too. So more exposure kind of fundamentals, figured out what the US is, figured out the CS. We're trying to do things to do target expectancy violation. And so, of course, part of this is reducing or eliminating some of those safety signals that are there. So things that are called conditional inhibitors are things that have this negative associative charge, and they decrease expectation that the US is going to occur. So examples might be include anxiolytic meds, benzos, and different things in panic disorder, right? If I take this benzo, I'm less likely for my heart to lead to a heart attack. A safe person, if this person is with me, maybe a feared outcome won't happen, or this person's going to be able to handle the conversation if things go stale, and so I'm not going to get rejected, right? Compulsions and OCD. So because they decrease expectation in the broadest level of the terms, they negatively impact extinction learning and get in the way of exposure therapy. So it's one thing we want to sort of get rid of as many of these as possible, and particularly get rid of the really powerful ones. So as part of this, I think it's important to consider whether cognitive restructuring is something that we want to do with exposures. Cognitive restructuring is a great, and cognitive therapy is a phenomenal intervention. I do it all the time with patients. I don't do it in the context of exposure, however, for this reason. If you think of traditional Beckian cognitive therapy in terms of, working on decatastrophizing, working on perceived likelihood of something, if you're doing that prior to doing an exposure, you're in some cases helping the person feel that the feared outcome is less likely. Great as an intervention, but you're sort of getting in the way of the exposure that you're doing at that same time. If you want to do an exposure and you want to do it from this standpoint, then we want to maximize expectancy. We want to help that person really feel like, the dog's going to bite right now, because when it doesn't, there's going to be more learning. And so we don't want to do things, even helpful things, that reduce that expectancy. Clearly, more research is needed on this, though. The research is kind of at early stages in terms of looking at this and how it either can negatively impact extinction or an exposure or not. It's still something we want to look more at. Personally, I just don't do it prior to or after an exposure. It's something I do in other circumstances or for other presentations when I'm not doing exposure. But, that's sort of my opinion, and I completely understand people's desire to still use cognitive therapy. But that brings up a point that's been tossed around in the literature, which is, can some of these behaviors be used judiciously to help people do exposures? And the shorter answer is sure. Really, regarding any of this, it's all like a ratio, like how much excitation, how much are we getting that person to really think the bad thing's going to happen, versus how much inhibition, what things are present that make the person think it's unlikely to occur. We want more expectancy and less inhibition, right? Because that's going to maximize extinction learning. So if you have a safety signal that's not that powerful of a safety signal, and you're doing a really high expectancy exposure, you're still going to get some extinction learning. You're going to get less than if they didn't have the safety signal at all, but doing an exposure with a little bit of a safety signal and it's still a high expectancy exposure is still better than doing none at all. What we want to try and do is get rid of the powerful safety signals. Again, things like in panic, right? Popping a benzo or something like that is really bad because it's such a powerful conditional inhibitor that it probably washes out a lot of the extinction learning and associative change that happens. Other smaller safety signals, if you have to have them on board to get the patient to do the exposure, then like everything, it's a matter of pros and cons and negotiating with patients to try and increase expectancy as much as possible. Want to take a quick look at the questions. How about cognitive restructuring after exposures, articulating the extinction learning? So we're going to talk about that in just another slide. I just don't call it cognitive restructuring, but we're going to talk about that. So following exposure, here's the question to this. We want to consolidate extinction learning. So after a learning episode, after exposure, after learning experience, after fear conditioning in the lab, whatever it is, the process of long-term memory consolidation starts, and it extends, certainly within the first few hours are really important. And then sleep, we know, is very important, the first 24 hours. But essentially, right, our neurons are kind of talking to each other. And we want to try and maximize this process and trying to help all the new information that the person's gathering from exposure kind of soak in there. We want to enhance consolidation in a lot of ways. And this is where D-cycloserine attempts to intervene. One of the things we know that's non-pharmacological is that mental rehearsal improves memory. So repeatedly rehearsing an association, rehearsing an item is going to be important for enhancing memory consolidation. So after an exposure, both on our worksheets and organically through conversations, we've repeatedly discussed like, what did the person expect as a result of prior to the exposure? What actually happened? Were they surprised? We're repeatedly getting the person to see, hey, did the CS lead to the US? And repeatedly over time, getting the person to say like, yeah, I was expecting this to happen, but that didn't happen. Or yeah, my anxiety was kind of telling me this, but this happened. They're over and over, they're dwelling on that fact, kind of like a good form of rumination, if you want to think about it that way. And this is one of the things we do to try and most importantly, because we want to consolidate extinction learning. But of course, people who are anxious have a variety of processes or tendencies that might lead them to discount this experience, and they start ruminating about other things. And when they do that, they're again not attending, they're not directing their attention and their cognitive resources to what we want them to learn. Like, hey, did the US lead to did the CS lead to the US? It's really important to focus on whether the CS led to the US and not ancillary learning. Like, oh, I wasn't as anxious as I thought. And clients say this all the time, right? I wasn't as anxious as I thought. Wasn't as bad as I thought. Such and such happened. Validate that. That's great. That's really important. But what about this? What did we learn about this? I kind of draw them back to that learning. And we do that over and over again. It doesn't have to be super long to try and help them soak in that information a little bit. This is where some what people term cognitive restructuring following exposure might be helpful. I think it's great. I think there are various instances where clients are going to want to, discount this or debate this. And I think it's important to try and counteract those processes. And, I think even if you're doing cognitive restructuring, a good sign of cognitive therapy, of course, if there's too much kind of conflict going on in the room, that's like not a good sign if somebody's really entrenched. And so you want to avoid that. But I repeatedly just lead people back to what did they say beforehand? What actually happened? What does that tell you about the likelihood that you're rejected? And so one question is, and there's a few questions that I'll address in a second, but what happens if the client is unsure whether or not the US happened? And we see this a lot in social anxiety disorder, right? Like, well, I don't know what the person was thinking. They could have been, thinking poorly of me or not liking me. No one would do that. And so again, that's why we have those behavioral indicators of what rejection might look like. That helps us. But did they abruptly end the conversation? Were they not receptive or answering your questions? Did they scowl at you? So what does that tell you about the likelihood that rejection happened? Again, this isn't an on-off switch for many things. It's often a dial by degrees. And if we're chipping away, like knocking down how many degrees that it feels sort of likely, we're getting some error correction. We're getting some extinction learning, and that's great. The other thing is I never get in a tug of war with a patient about this, because no one exposure is the end game. Okay, right. Well, no, these things didn't happen. And yeah, we're not sure if you're not 100% sure whether or not you're rejected, but it's telling you maybe it wasn't so likely. Let's keep doing it. Let's keep doing the exposures to see. And after tons of exposure, if rejection didn't happen, that's going to be a more powerful experience. So one person asked, the notion of maximizing expectancy violation seems to be a no pain, no gain principle. Would I agree? Yeah, I mean, to some extent, I think there's probably, if a person isn't experiencing any distress at the result of doing an exposure, then either they're really not expecting the bad thing to happen, in which case the exposure isn't targeted properly, or there's some other things that are going on, or they probably wouldn't need you in the first place. Like, the reason why our clients are coming to us for these difficulties are because they elicit some distress. And to some extent, unfortunately, the only way to get over that distress is through it in some way. That doesn't mean it should be torture. Exposure should never be torture. It's always done collaboratively. It's always done with support and validation and encouragement and a lot of praise. And it's also done with pushing people a little bit, but pushing them gently, because we know what they're capable of and how resilient they are. And somebody is free to refuse to do an exposure, and then we wouldn't abandon exposure completely. We might back off to something slightly less just to get some exposure going. Somebody can end exposures. I've had people do that too. And the idea is to validate that a little bit, and that's difficult, and try and get back on the horse and do exposures as quickly as possible. But there will definitely be some distress in any type of exposure. So one person asked, most clients will expect the therapist won't recommend anything really dangerous. What are the ways a therapist can recommend exposure without decreasing expectancy? Great question. There is, of course, some indication that, the patients know the therapist's not going to actually do anything that's going to harm them. The thing is, and the fortunate thing about anxiety is that people might respond that way rationally, so to speak, but deep down their anxiety is going to be like, forget therapy. When they're in the midst of exposure, they're like, this feels scary, this feels dangerous, this feels like the bad thing's going to happen. So when I'm talking to folks about their expectancy, that's why I often ask them to sort of rate things from their gut, what their anxious mind might tell them, what PTSD would tell them, what OCD would tell them, to try and tap into that amygdala-based expectancy about what's actually going to happen. And so I think it's less of a detriment than we might often worry about. That being said, there are certain ways, and this is a good point that you're making, that therapist itself and therapy can become a safety signal. And, that's one reason why we do therapy, not only in session, but outside of session and through homework, that they're doing tons of exposure without the therapist as well, too. Somebody asked, for example, in social anxiety, like, how do you respond when, as an example, the client is rejected during the exposure? This sometimes happens, particularly in social anxiety. And social anxiety disorder is one of the few disorders, I think, where the US still occurs, for people. All of us have probably experienced rejection on some level. I mean, if you do research, you certainly have, right? In terms of papers and grants and all these things. So how do you respond? I think I tend to, well, a couple of ways. First, it's actually far less likely than the person thinks. And so it is still a rare occurrence when I do exposures with people for social anxiety, and we've been doing it at UCLA for years, just because generally speaking, most people tend to be polite enough that there aren't overt signs of rejection, but it still does happen. Dating, different examples, it happens, in which case I don't dwell on it too much. Depending upon the person's distress, we really validate how difficult that is. I might, reflect on, hopefully this isn't one of the first exposures they're doing, which would be more difficult, but reflect on some of the prior exposures they've done and what they're gathering from this one rejection out of all these exposures that they've done. And then I try and get them back on the horse again as quickly as possible, trying to view this as one instance among many. Because again, particularly for social anxiety, rejection is something that is going to happen in people's lives. So it's not uncommon that it'll happen. It's not inconsistent with a learning perspective to talk about, well, was it as bad as you thought it was going to be? We won't have time to get into that, but that's sort of targeting the intensity of the US, like how bad it is, and making it feel or experiencing it as less intense or as less potent as maybe the person experienced. So, and that's a clinical thing people might do. Well, what are you learning? You can tolerate it, you can get through with it. Looking at self-efficacy, that's great too. And then get back to the exposures that are targeting extinction learning. Thanks everyone for great questions. So fundamentals of exposure. Continuing. One of the things then, once we've done this, is we want to repeat exposure to the principal CS, the thing that is most predictive, with slight variations as much as possible. One of the things is that repeated exposure is really necessary for extinction learning. When you look at the basic literature drawn from animals, I think the human literature is getting this wrong a little ways, but you need tons of extinction to counteract original sort of conditioning. And I think most clinicians really grossly underestimate the amount of exposure that's needed. And you see this in our clinical, not ours, but the field's clinical work looking at homework compliance and adherence, that just generally speaking, the the more practice people do, the better they respond to treatment. And that's particularly true for exposure. This is always an area of difficulty because behavior change is hard, and people, both because of avoidance and fear and other things that are going on in life and a bunch of other things that make doing practice between session, whether it's exposure or not, difficult. And it might even be more difficult for some types of therapy that involve like facing distress, right? So what this means is it's not that it's hopeless, it's that I think clinicians really need to spend a large amount of time, both in session and across sessions, focusing on designing homeworks, homework compliance, reviewing homeworks, like praising people, reinforcing for homework adherence, because we just need a lot of exposure. And the idea, I think oftentimes people might do a little bit of exposure and feel like that's enough, and it really isn't. It's not a sufficient dose of exposure. So as much exposure as possible is the answer to how much, but routinely, I try and do 3 to 5 times a week of people doing exposures. It depends on the difficulty and the logistics behind an exposure, but as much as possible. It's also really important to continue to expose the client to the principal CS, the thing that's the most predictive. You can have slight variations in the context, which is really helpful in, if you're doing exposure to conversations, so maybe different types of conversations with different people, that's where you're getting the variation. But the idea is, this person feels initiating and maintaining conversations is going to lead to rejection. We're going to hammer that in with exposure rather than switching stimuli so frequently. And sometimes people do this when they've done fear hierarchies, is they'll do a week at one level and they'll jump up to something that's completely different. Part of learning, extinction learning, is fairly cue and outcome specific. And cues, stimuli, are made up of a variety of different elements, like we've alluded to before. So if somebody's afraid of they were bit by a pit bull, they not only fear and expectancy of getting bit is probably related to the notion of dogness. That's right there, the particular size of the dog, the breed of the dog, the color, all of that sort of gets some excitatory strength, with the most salient elements getting the most of them. And when you jump around to too many, so if you do exposure to that pit bull or exposure to a similar type of pit bull, extinction is going to accrue to those elements. And then if you jump to a completely other dog, you jump to a greyhound, right? You're still going to get some generalization of all the extinction learning that you're accruing to this notion of dogness, but this is a different, it's gray, it's skinny, it's tall, all of that's going to start getting extinction learning. And you're leaving all this other stuff from the other pit bull kind of just staying at the level it was at. When you jump around too much, you can think of it as you're leaving like a certain level of the fire burning, right? It hasn't burned down completely because you haven't done enough extinction to those elements yet. And so we tell people when we train them to try and focus on the thing that's most predictive, do that as much as possible, different contexts, slight variations to help generalization, and then add some adjunctive exposures along the way, but really still focus on that thing that's the most predictive. So for panic disorder, maybe it might be sensations of rapid heartbeats, or you're going to do things with intense exercise. Maybe you're going to do things in different contexts, different types of intense exercise. Maybe the person also feels shortness of breath is one too, although the rapid heartbeat is a bigger one. So we're going to keep doing the rapid heartbeat one, but we're going to add in every once in a while some voluntary hyperventilation here and there. So we're going to add some exposures, but we're going to keep our focus on the one that's the biggest predictor, because that's going to give us the most benefit from exposure therapy. I want to take a quick look at questions. So this is a really important question. But in this model, do you even need patients to rate their level of anxiety like SUDS, or that is essentially irrelevant? I don't personally do it that often. Every once in a while, I'll sort of ask if I feel like somebody is not distressed at all. And I'm kind of wondering, like, is the exposure sort of working or what's going on? But really, SUDS ratings don't matter. Michelle's 2008 paper, which was one of the big clinical translation papers, of course, that many people are familiar with, reviewed a lot of the literature on what had been termed habituation in terms of within a session and across a session, and decrease in SUDS within session, and even Edna Foa's group acknowledges this, like, and has changed their model, like, doesn't really mean anything. So how much SUDS go up and down in a session isn't really important. People still advocate for the importance of between session decreases, but that's another conversation. But I don't, to answer your question, I don't really assess that. What I will show you on some of our worksheets pretty soon is I do assess sort of what we call expectancy ratings, like how likely something feels. That's what the self-report index that I tend to use, but I don't often go by SUDS ratings. Just a few more questions want to take a look at. What's my view on using abdominal breathing, diaphragmatic breathing exercises to increase tolerance, acceptance to discomfort during exposure? Kind of depends. Like, I tend not to use it at all in panic disorder because reducing physiological arousal is such a potent conditional inhibitor that's really going to get in the way of extinction learning. I generally, don't often do it in the context of other exposures, because even when it's not a direct inhibitor, like, the person doesn't feel, okay, if I control my breathing and reduce my arousal, it's less likely that a shooting is going to happen in this crowd, right? They don't actually believe that. But anxiety has this benefit of making us think threat is more likely. So I like anxiety to be present for the purpose of exposure because it enhances threat expectation. And I try not to do too many things that diminish that. That being said, again, if it's not like in panic disorder, and if it's not one of the things that's directly going to kind of like wash out all the extinction learning, if that was the only way to get my client to do an exposure, I would probably do it because there would still be a lot of extinction learning that would happen. So a lot of this involves really what I hope is sort of thoughtful, individualized consideration of the client, their presenting difficulties, the nature of their sort of fear association that's present, really thinking through, are these stimuli going to enhance that, detract from that? What are the pros and cons? And it takes a lot of that, I think, work to think about whether the exposure therapy is going to be beneficial. That being said, I'm, a big fan of diaphragmatic breathing just in general. Beyond, another question was, beyond interview questioning, are there good methods for exploring the primary CSs? We really use kind of a semi-structured interview, what we think of as what we call our Opdex Nexus, which I'll show you an example of, and is in our most recent published paper. That's sort of our method for mapping out this kind of associative network. How does my understanding of exposure differ or not differ from the unified protocol? It's been a while since I've looked at the unified protocol. And I know it's efficacious. I mean, the team at Boston is phenomenal, of course. I don't think it's inconsistent with the unified protocol, and meaning that I think you could apply this method of exposure within the context of the unified protocol while doing other things, for sure. I will say that I'm not sure if the unified protocol talks about these mechanisms and processes in the type of detail that we do, and therefore maybe, and this is an empirical question, wouldn't be optimizing exposure as much in this way. So my thought would be that the unified protocol is great. You're doing a lot of these other things that if you're doing exposure and you feel there's a strong Pavlovian element to do exposure from this standpoint within the context of other things that you're doing within the unified protocol, as long as the two don't conflict. But it's been a little while since I've looked at the protocol directly, so I'm sorry I can't answer more specifics. And is there any data that I refer to when considering how many repetitions of an exposure are needed? Like, is there an estimated number? Are we still aiming at habituation over time or disconfirmation of fears over time? No hard and fast answer. It's as much as possible, you are aiming for over time for that expectancy rating to continually to start decreasing, for people to be more willing to do exposures. Certainly, even though I don't track SUDS ratings and don't think within or between session changes in distress are the strongest predictor of outcomes, I certainly expect people to be less afraid and distressed as a result of treatment. If not, then what I was doing was not working. So in terms of repetitions, I tend to, again, just do a lot, and I try to focus on, again, the principal CS as much as possible. So trying to think. So if I'm treating panic disorder, when I treat panic disorder, I'm going to focus on the particular interoceptive sensation that's most predictive, and I'm going to be focusing on that the whole treatment. As much exposure to that as possible. Again, amping up expectancy, doing it in different contexts. And then I'll add in other interoceptive sensations, maybe for a few exposures here and there. We'll add in different contexts like being home alone or away from home alone that make it what's called like a positive occasion setter that makes it probably more scary. But I'm going to do as much exposure as possible to that thing that's the most predictive. So I think just tracking persons, decrease in expectancy over time is a good way to do it. Being aware of how distressed they are, how bothered they are through interview or direct questionnaires is another good way to sort of monitor progress. And yeah, over time, you should see people expecting the feared outcome less, being less afraid, being less distressed, less intrusions, less avoidance, all the whole sort of cornucopia. When I say associative learning principles apply to exposures that are targeting contamination OCD when the feared consequence is experiencing disgust. Yes, these are great questions. So I'm going to answer the next two, and then we're going to kind of go on and see if we have time or just try and save more to the end. So yes, I think disgust has often been discussed as what's called an evaluative response, which has to do with the valence, the liking or disliking of a stimulus. And that is involved in Pavlovian learning. Again, shout out to all the Leuven folks for their brilliant work on evaluative learning processes and counter conditioning and things. So yes, disgust is a particular type of conditional response. And to some extent, the person might be experiencing disgust because disgust is an evolved mechanism often for dealing with, things like that are going to be contaminants, right? That are going to make you ill. So there might be some expectation of illness. People often experience moral disgust too, and that's kind of different. So I think it depends as long as there's a Pavlovian element in place. The liking or disliking of a stimulus changes much more slowly than the expectation that a bad thing's going to happen. So I wouldn't track like how not disgusting something is getting over time. I would be tracking more like if there's a particular feared outcome, is that the expectation of that feared outcome, is it decreasing a lot over time? That would be more my indicator with the knowledge, and I would share with the patient that some aspects of disgust will take some more time to decrease. And that's how I tend to handle disgust in OCD, as long as there's a Pavlovian nature. If there's not, and it's just, I don't think anything bad's going to happen, like touching sticky substances, it just feels gross and I feel disgusted, then again, that's a way that we would maybe doing exposure or other interventions that aren't involved in associative learning processes. How would I do exposure and extinction for fear of flying when the US, right, dying in a plane crash and the client flies and does not die and still thinks, am I safe now, but what if? Fear of flying is a harder one because people, unless, maybe you're treating some rich athletes and actors who can fly all over the place, but it's hard to do frequently enough to get tons of extinction learning. So the fact that they're still thinking, I'm safe, but what if it were to happen the next time I fly, is partly just because the person is just not getting enough exposure and not enough extinction to that. So they're not getting, that dial's not getting chipped down enough. That's a real barrier to doing exposure, period, with fear of flying. And so other interventions might be important. This might be a place where you do more cognitive restructuring. This might be a place where you add in, because the person might not get enough exposure to justify or to garner any extinction learning. Maybe you do add in some other coping strategies for when they do fly. And that's sort of, you're working within some logistical constraints. So these are phenomenal questions. I'm just going to hold these, and Sasha can hold the ones I haven't answered, including to one in the chat. And we're going to get back to these as we get through some things. So here's the first page of, let me just make sure. Yep. Of our Opdex Nexus. Again, this is in our most recent publication. We also have an accompanying sort of list of questions that help guide people through doing this. So again, we had different iterations of this. This is our current one. Since we don't use a hierarchy, we needed some way to map out all these different things. So we go through first trying to figure it out what the feared or distressing outcome is with somebody and ask just like I did that. We then go through all these different categories of things that are increase expectation that the US might happen. And we figure out which ones are actual conditional stimuli or what I said are occasion setters, right? Things that they don't directly predict the US, they just make the person feel the US is more likely when they're confronting the CS. So again, example of occasion setter in panic disorder might be being alone. Right. So I know I'm not going to do exposure because I'll ask and I'll identify and I'll be like, oh, that's an occasion setter. That's not a CS. And I just use those terms myself because I'm familiar with it. But, is it a predictor or not a predictor? That's another way of thinking about it. So we go through physical sensations, certain situations and settings, objects, thoughts or images, and find which is like the strongest predictor. Theory, clinical experience, and empirical evidence can help you figure out which categories are probably going to be the most related to your client's particular presentation and which ones are less likely to be relevant or more likely to contain occasion setters, non-predictors. So physical sensations are a big one for panic. Situations and settings are what we often talk about in terms of social interactions. That might also be like crowds and PTSD. Objects are really relevant for a specific phobia, but probably less relevant for the other disorders. Thoughts or images might really come up in OCD. When they're really predictive of a feared outcome happening, they might also come up in other disorders, but they're not an actual predictor. They're a conditional response. Like people just get intrusive images, but they don't feel that the images themselves are predictive of anything. So figuring that out is how we map things out. And then on the other side are all the negative occasion setters, they're called, or conditional inhibitors, the safety signals, behaviors, compulsions that people do that decrease likelihood. These are the things that we use the term throw out, right? These we want to test out and we want to throw out as many safety signals as possible. Are there particular thoughts, mental compulsions, or cognitive restructuring, or things that people do, any objects or people, right? Like a safe person, having a phone with them, carrying medication with them, these types of things. And we map that out and figure out what would the ultimate exposure be for this person. And this might not be an exposure we do with somebody, or certainly one they do right away, but it helps us figure out what is the ultimate test of their feared outcome, because that's what our goal is, or it helps us figure out like all the different variables we can manipulate to try and test out their fear best. Right. So this is what we use, and we use in our research studies and with patients when we're doing exposures. Just quick time check. Okay, we're doing good. This is one of the examples of a worksheet, again, in our recent publication in the exposure plan, where we sort of write out, and this is what people use between session. What am I testing out? Again, trying to really operationalize the US and making sure there's a clear testable outcome. How are they doing it? These are things that we use to describe some of the processes that we're trying to target. And I didn't talk about all of them today. So throwing out are the safety signals we want to throw out. One of the things I didn't talk about, which is important, is staying with it, or what is known as attentional salience. When we do an exposure, when we have any sort of learning episode, and I mentioned this briefly, all of the learning that happens gets funneled to the most salient elements of the stimulus that are present, right? I've always thought of it as like, for some reason, like little birds when they're like chirping for their mom to like feed them, and the loudest bird is going to get all the food, right? So that's where all this sort of learning is going to get funneled. And so we want it funneled into the conditional stimulus, into the aspects of it that are the most feared, right? So we encourage people to really focus on that to help direct all that learning into the feared out stimulus, so that we get extinction learning funneled in the right place. So this might be really paying attention to and maintaining eye contact in social anxiety. It might be really paying attention to the physical sensations in panic disorder. It might be really, and I'll show you some exposure examples in a second. It might be really paying attention to the notion or the thoughts of the ideas about all these scary things that could happen in this moment. And we want people to really attend to that. Combining it is our term for deepened extinction, which we're not going to talk about today. It's more of an advanced strategy that we talk about in our paper. Same with face it, which is for occasional reinforced extinction, which is also in our paper and not something that's very applicable to exposure. But this is part of the plan that we use to design things, and putting it all together, help the person write out their exposure or they write it out. Part of any CBT or exposure therapy is training people to be their own therapist. And then the second half of it is the log, where here's an expectancy rating, where before we do an exposure, we get somebody from, again, in their gut, how likely does it feel that their particular worry when doing this exposure is going to come true? Afterwards, some of this is data that we use for some of our studies, but we also sort of can be helpful to ask at what point during the exposure, when your expectancy was at your peak, how did it feel? And then these ones, are ones, if you're not used to doing it organically, that can guide you in sort of that questioning, that cognitive restructuring, if you want to call it that other types of mental rehearsal afterwards. But more importantly, when patients are doing this for homework on their own, forcing them to sit down and reflect. And again, consolidate that learning. Did their greatest worry come true? Simple yes or no. Some people might say, I don't know, right? How did they know? Again, deepening that description of it, depth of processing framework, right? What happened as a result of, what did they expect to happen as a result of doing the exposure? What happened? Was there any surprise there? Was that not what their anxiety, their OCD, their PTSD told them? What did they learn from doing this exposure? Again, doing this and helping people kind of really reflect and dwell on the non-occurrence of the US, which is a big part of exposure therapy. So here's some example exposures, just really brief ones. They don't have to be, I'm not saying this is like the only way to do an exposure, that some of these are taken from ones you might do early in treatment and, that still elicit a higher expectancy rating, but aren't the toughest exposure you're going to do with somebody. So in panic disorder, for somebody, intense physical exercise for 10 minutes while away from home, for some people, I might advocate a typical or a certain level of heart rate. For some people who are really specific, if my heart rate's over 100, that's scary. We try and get it above that. Other people, it's just a feeling of intensity and we try and match that. Maybe they don't have a cell phone or a safe person. So throwing away those safety signals, really focusing on the sensations of a rapid heartbeat during the exposure. And their goal is to test out, right? If increased heart rate leads to passing out, that's the sort of US for this person and what they're targeting. And for this person, we ask them to repeat it 5 times over the week, varying locations. Maybe they do some in the evening, some in the morning, some further away around their house, like all these different ways, constant exposure to that principal CS as much as possible. And of course, 1 week is not going to do that. It's not going to be the end of treatment for this person, right? They would need multiple weeks and months of exposure therapy. Depending on the severity of the panic, we would constantly work to increase expectancy as best as we could, although we would expect to see expectancy decrease over time. Social anxiety disorder, initiating, maintaining a conversation with a coworker you don't know well, right? Maybe knowing them well would be one of those safety signals. Maintain eye contact. That's that attentional salience, focusing with it. Don't rehearse what you'd say beforehand. That's one of those safety signals we don't want them to do. Goal is to test out if they're rejected, and we have some operationalization of this, right? Some, not just because particularly in social anxiety, there might be a feeling of, well, I don't know, or maybe I was rejected, or they're quiet for a second, right? Interpreting ambiguous or ambiguous stimuli as indicators of rejection is sort of part of what happens there, right? They might repeat 3 times over the week with different coworkers. This might be one thing we repeat throughout treatment, but also do some adjunctive different types of social exposures. Maybe they would go to a party. Maybe they would ask a friend to coffee. Maybe they would disagree with somebody. Things that in some ways, for those of you who have a good amount of experience in exposure therapy, it's not, this might not feel like a paradigm shift, which is great. Like what it might feel is like a more honing in and targeting of some of these processes. And that's important too, hopefully. Contamination OCD, and I know there's several OCD folks on the call, and this is just one example. I always admire OCD therapists and their creativity with which they apply exposure therapy. But again, we want to get repeated focus to something and not jump around to different types of things as much as possible. So for this person, if public surfaces are kind of the principal CS, door handles, maybe it's public toilet seats, that's a big one for people, right? Other types of things, touching it, rubbing their hands on their eyes and mouth. You know, I've had people, right, lick their mouth after doing that. Really focusing on the idea that there might be germs they can't see. No washing hands or face afterwards. They've already ingested the germs, so to speak, but sometimes doing some of those compulsions would feel like that person, sometimes that in an unrelated way, is going to undo the exposure, or is going to prevent their feared outcome, or just helps feel like they're getting the germs off, and we don't want to do that for a period of time. And test if you become seriously ill, fever, vomiting with 24 hours. Some people might feel worried about getting sick within a time frame that's a little bit longer. It might be days to a week, still testable. For things far in the future, that's where we're in that other zone that we were talking about before. And a veteran with PTSD. So going to a crowded grocery store at lunchtime, staying for 20 minutes, repeatedly placing your back to the entrance for several 1-minute intervals, focusing on the fact that numerous people are walking behind you without your knowledge, refrain from scanning the crowd while doing this or beforehand, or remaining near the exits during the remainder of the exposures. People want to sometimes feel like an easy escape. Goes to test out if there's a shooting, right? Repeat 3 to 5 times over the week, vary locations, different times, different size crowds. This might be an example for a more threat-related physical violence component of PTSD. So want to pause here just to talk about some questions to see if people have. First, here's my contact information at UCLA, as well as at the California Center for Anxiety and Traumatic Stress. Feel free to reach out for any reason. But now that we've come to this place, I want to open it up for questions. I really thank everybody who's shared the questions thus far. And I'm glad I left a good amount of time to check in. If there's any more, we'll go through all the questions that are here, but if there's particular questions or things that involve a little bit more complexity, we have some time to talk about that. So one person asked, in what roles may participation of support persons in exposure practices be helpful? Great question. Always assess whether the support person is detracting or impacting the expectation of the feared outcome at all, or the anticipated outcome. If it's detracting from it, then it's probably a concern, and we probably don't want to do it if possible. Or if we do it, we want to do it early on in exposure and try and get rid of that safety signal as quickly as possible, particularly if it has a powerful impact. Support people are sometimes helpful in the early phases with younger audiences, clients. One thing I didn't mention is I didn't take a thoroughly developmental perspective as we talk about this. I do work with some younger individuals as well, although the majority of my work is with adults. And I think although the same processes apply, there are other considerations and things to think about when working with adolescents and children in doing this model. Some difficulties, in terms of kids having a really hard time identifying what the feared outcome is and maybe not even knowing. Other types of things that are certainly something worth considering. And I know there are some child folks on there as well too that I'm happy to discuss in more detail. But parents, loved ones might be a component of those exposure practices. Again, I'm always assessing whether or not it impacts the expectation of the negative outcome. In what ways might it be helpful in helping people to get them to do exposures they otherwise wouldn't? If, again, maybe early on, this is a necessary thing that the person is unwilling to do it without. Other ways is if there's other reasons, logistical or otherwise, that the person might help motivate them to do the exposure, deliver them to the exposure area, and then leave. I think, we have to do a little bit of constant assessment for anything about whether it's impacting expectation and figure out how to impact expectation the least. But I think individuals in our life maybe have a more prominent role in reinforcing us for exposures we've completed. So all the work on how partners, family members can support individuals who are engaging in exposure therapy, and really not accommodating, of course, is one element, but also just providing validation and support and encouragement is a huge component, I think, for many people. So wanted to look at some of the questions there. And this is going back, so it's totally okay if it's from other slides, but somebody asked, are there ever situations where you'd focus on decreasing anxiety or increasing anxiety tolerance before aiming for extinction learning? A person who has a dystonic reaction, neck twisting when anxious, which definitely interferes with skillful driving when in the high speed lane. Yeah, I mean, I would certainly want to, if it's ever going to get in the way of doing an exposure safely, then I would definitely want to target that. And I think, again, I try and do exposures with as little safety signals as possible. But in this case, if the fear is sort of car accidents when the person's driving, one of the things is we want to make sure they can drive safely, of course. And the other is that they're attending to stimuli in the environment. So they're sort of learning that as much as possible that their fear is unlikely to occur. And if there are things that are happening that are overly distracting, that might be another reason why we might want to do it. And so with a lot of these, and these are really good questions, I tend not to take like an all or none approach to some of it. It's all, and I know this is a horrible way to answer like it depends. And it really just depends on everything. And I'm constantly assessing with my own patients when I supervise and train people, and just to what degree is that impacting sort of expectancy, and make decisions from there. And sometimes I'm deciding in the spur of the moment to allow something or not allow something to, based on that evidence. So, but really good to just be aware of the possibility of that, and then to proceed to assess from there. So somebody asked, curious about exposure and extinction learning to fear of being in a mass shooting and illness and health anxiety. Feel free to let me know if there's anything in particular you're curious about now that we've talked about it. I mean, mass shootings, and when I've worked with veterans and some younger people who might be concerned about that, it's usually crowds in public places that we're fears of. So doing in vivo exposure in those areas, for some people, unfortunately, just going to school would be an exposure in that instance. Certain crowds, movie theaters, grocery stores, restaurants, doing exposures to those situations while refraining from some of the powerful safety signals. For some people, that might actually be bringing a weapon, to be honest. Other people, and for anybody who's worked with veterans, know, like scouting the area beforehand on Google Maps and looking at ambush locations to make sure that's not happening, and looking up exits and doing all the scanning, that all these safety behaviors we don't want people to do in the situation would be something to consider. Illness, health anxiety, I think, it kind of depends on the nature of the feared physical illness, and so I'd be curious to the person who put up this question, if you have a more particular question with illness and health anxiety about how it may or may not apply. I'd love to talk about that. The recent publication with the worksheet shown is I can look it up before we leave. I forget the title. It's something from 2022, optimizing exposure therapy with the Opdex Nexus. It's Michelle's and I are joint first author. Tom Zabazinik's on there too, as well as Bram Vervliet, who's from Leuven, is on there, our kind of core team when we publish these. So it's from 2022. Michelle obviously has 8 million publications every year, but if it's from 2022, I do not have 8 million publications. So if you look up me and Michelle from 2022, you'll only get a handful. So, and somebody posted that. Thank you so much. Yeah, so question coming up to this model in PTSD with guilt specific to the details of the index trauma. So guilt and shame and self-blame in PTSD is an interesting component that I don't always think a particular Pavlovian element applies for. And in PTSD presentation, there might be a lot of things going on that we're trying to target. So for some people, you might be doing some more of this in vivo exposure work that's targeting fear of violence, of certain things, or fear of interpersonal violence and walking certain places, being with certain people, fear of, sexual violence occurring. And then there's certainly aspects of the trauma memory itself, and some of the guilt that you mentioned. There's might be some extinction learning that happens in regards to shame and guilt that occur when people share details of the trauma and are met with validation and warmth and support. I certainly think that's a viable interpretation of the process that happens there. There's off, that doesn't mean we encourage people to go telling the details of their trauma to people, because people might not respond with validation and support. And so with really pervasive guilt or shame, some people might take a prolonged exposure work approach and just do exposure to the intrusive image. I do not take that approach necessarily. I've done a lot of cognitive processing therapy and was fortunate to train with Patty Resick. And so I sometimes take like a cognitive processing therapy approach to some of that guilt and shame. And again, it kind of thinks this ties back into, if there's not a predictive forward-looking association that's present, then it's really might not be the best fit for an associative learning model. That doesn't mean other types of exposure or other types of strategies would not be helpful.
The question regarding illness anxiety, they added some more information. It's at the bottom of the Q&A.
Okay. This client is worried about nearly any illness, cancer, parasite, long COVID, and having it go undetected or diagnosed. Includes fear of very rare untreatable conditions. She also has OCD and lots of compulsion, safety behaviors, excessive research, doctor visits, avoidance. Totally makes a lot of sense. I think if there was a particular illness, I think I would want to focus on, if it were me, and consider the illness that they're most afraid of, if there's one. Also, illnesses that are most vulnerable to being tested out. So if somebody, if they're anticipating a particular type of illness within the next couple of days or next couple of weeks from doing something, touching something, having particular physical sensations, then you might be able to do exposure from that standpoint. Certainly reducing any of the compulsion safety behaviors, which I'm sure is difficult for this person and something you're working on, right? In terms of the research, the doctor's visits, the avoidance. There might be, again, for something that's anticipated to occur far in the future, or there's no way of this person of knowing that, that an additional approach not covered here would be more, so maybe you would take a self-efficacy approach in terms of tolerating the uncertainty that's around it. Maybe you would take a cognitive restructuring approach. Maybe you would take a combination of both. But if there isn't something that's more directly amenable to violation, like a particular thing is going to predict developing this illness, either in the short or long term, then it's going to be hard to apply this model to that. If they feel they've already had it, or like people who feel they have a genetic predisposition to something, there's no, that's not something you can expose somebody to because their genes are already occurring, then you have to take another approach to targeting that health anxiety. But it's a really great question and a complex presentation to deal with, certainly. So somebody asked, what about heart palpitations and not just rapid heart rate? Really hard, right? We can't often mimic a skipping heart sensation. Most of the people that I've worked with panic disorder who fear rapid heart palpitations and a skipping beat tend to also feel rapid heart rate, or tend to feel other types of physical sensations. So I tend to focus on those. understandably, like if heart palpitations are the principal CS, why you'd want to focus on that. And we're often logistically constrained by what we can expose people to. So I still think you can gain a lot, or the person can gain a lot, and you could probably have a very successful treatment outcome if there are other physical sensations that the person can feel that are predictive of a heart attack. The other thing is if they experience heart palpitations regularly, or they notice them, but they're just not predictable or controllable, is that you can work with the client to take that as an exposure opportunity. Okay, so coming up with a plan that when heart palpitations happen, what would leaning into that sensation look like in a way that feels it would lead to their feared outcome, like having a heart attack, right? So when they get heart palpitations, can they go and do some intense exercise? Can they do some hyperventilation as soon as they feel that heart palpitation? Can they use that to turn it into an exposure opportunity wherever they are? And it probably won't be in your office, to use that, and with whatever criteria and you develop with them, to turn it into something that they can test out and get some extinction learning too. Was I stating that psychoed on associative learning is important for the client's positive outcome? I think it is. I mean, I think I always want to be transparent with what I'm doing with folks. And so I always describe things in detail. I'm honest with them about targeting learning processes. I just don't use jargony terms. When I do psychoed about extinction learning and exposure therapy, I often use various specific phobia examples because they're clearer and easier to use, but I want them to know. And most people, when you present it intuitively, get the idea that they need to learn that something they're worried about is unlikely to happen. The pushback people often give is, I've already done this before. And by that, they usually mean they've tried to push themselves to face their fear, so to speak. If you dig a little deeper, they've usually done it infrequently, right? Because we need a lot of exposure to do it. And they've done it with tons of safety signals. So that's one common feedback to that, or they feel like it's going to be too difficult. In that case, we talk about going in a structured, systematic way, supporting them along the way. But I think psychoeducation for anything we do is an important part of motivation for treatment and positive expectancy for treatment, which we know across various types of therapy are important for outcomes. So I'm a big fan of psychoed. Suggestions for helping kids identify the core fear. I'd love to hear if you have a particular presentation you could chat real quick. Again, I tend to go with, depending upon the child's presentation, I probably, I always start asking Socratically and try and, I might offer some hypotheses about what they're worried about to see if I get a bite, and I also tend to, assume certain things could be going on based upon clinical experience and the existing literature, right? So if we're getting some kind of behavioral inhibition, shyness, social anxiety related things, I usually assume if that's going on, and I've ruled out other aspects of presentation, or the presentation, that it'll probably be some social anxiety, social evaluation concern, in which case I might offer things, and I'm depending upon the child's age, and under high school, I'm not going to say like rejection, but, people being upset at you, or people not liking you, or being mean to you, or not wanting to be your friend, might offer things to see if that happens. If you have, separation anxiety, is it about bad things happening to your parents when they're gone, about them not coming back to pick you up, various things. I kind of like offer suggestions and sort of depend. And with OCD, similarly, depending upon what seems like some of their compulsions might be, or if I have an indication of what some of their obsessions might be, I might be able to offer an educated guess about what some of the feared outcomes would be. And when all else kind of fails, like, are they worried about something bad happening to them? Are they worried about something bad happening to their loved ones? Are they worried about it happening right away? Are they worried about other people causing harm to them? Like even vague things like that are enough to start approximating treatment, and you might get some more information as you keep going. What exposures could be helpful with a child afraid of thunderstorms? How can you work with a parent who has, oops, I skipped one, but I'll get back to that, who has similar fears when doing exposures as homework? Yeah, thunderstorms, so the loud noises one and everything, it's probably unlikely that there's a particular feared outcome. And depending upon the child's age, they might not be able to identify it anyway. I think this is more one that's akin to like building self-efficacy to be able to tolerate that. So I might do exposures, and when I'm doing exposures to tolerate self-efficacy, which I have done occasionally with much younger people, I do sort of do coping skills, because part of it is allowing the person to learn, because there's no extinction learning that I'm worried about getting in the way of, right? So in that case, then anything that helps them feel like they can cope is going to help them learn that they're efficacious in coping with that. So again, it's all about the mechanism you're targeting. When we go back to my first slide, which was about this is what exposure is, but it's agnostic to the mechanism. It's because it depends how you use exposure. And again, most of our talk had focused on extinction learning, because I think that's a principal concern for most presentations that we've talked about, but as we're talking about, not all. So with this child, there might be exposure to different types of loud sounds, different thunderstorm recordings at different levels of volume, various pictures. It depends how significant the fear are, videos of it. And I think for parents as well, to not model that type of anxiety, is the parent would have to learn some coping skills for themselves or do their own exposure to be able to appropriately model how to relate to that, or if the other parent can help with the child do that exposure. But I think anytime, if the parent is modeling that fear, that's going to be an important source of fear maintenance within the home. A client with a huge disgust to pregnancy and OCD and the big belly. She has had nausea, but has not vomited, but I suppose the exposure is insufficient because she's not pregnant. Any suggestions? So the fear is that she will become pregnant, it sounds like, and she has a disgust reaction to that. It's interesting. I mean, and if the person is sexually active, and I mean, if they're not in a committed relationship, maybe they're using protection, which is, I think for this case, I'm not sure that our model is kind of the most appropriate. And I think I might, sounds like what you're doing in terms of exposure to pictures is fine, but I might also be wondering more about the nature of the disgust and any of their beliefs around pregnancy, and if there are expectations that they should be pregnant when they don't want children, and all these things that might be worth exploring. We haven't talked about counter conditioning as a treatment option, which is, I think, more complex than we have time to get into, but that's about like pairing things with positive outcomes to try and change a negative association to something that's more positive. Possible that it could be useful here, but again, I think I'd be really curious. I'm very curious about the nature of her distress, and whether it's feels because of socialization or family pressure she has to get pregnant. Sort of curious if that's going there. So and how do I increase the buy-in for the client to do and continue to do these exercises? So I think psychoeducation up front, like we talked about, is really important. I think successful exposure experiences tend to build upon themselves as people gain momentum and start, there is a real sense for a lot of people of restricting their life, of course, and depending on the severity, and I've worked with people who are housebound, the amount of pain and suffering that is there for that, as they start to face these things and learn that the bad thing's not going to happen, but also, of course, they're feeling some good about themselves and ability to face that tends to be a little bit of a momentum builder. There's inevitably with every client, troubleshooting and fear and avoidance of homework, and it's about validating and gently encouraging and supporting and trying to troubleshoot if there's structure or ways to help them to do exposure. Kind of the shorter answer is any sort of motivational work or logistical work in terms of structure that you can get for people to do exposure, that once they start doing it past the beginning phases of it, I tend to feel like people usually gain momentum. There are some people where it's a slog, the whole treatment, and it's constantly a matter of encouraging and dealing with avoidance and compliance, if we want to use that term, and the difficulty. And that's just kind of, they're just going to slog through it and go bit by bit, even though they might end up at the same place as somebody who went through it all. They might end up in a wonderful place, but it's going to take a lot of work on your part, to really do that. I think it's important to examine functionally, besides just straight avoidance, whether there are other things that are getting in the way from that person, engaging in the process. I know we have 5 minutes, so I'm going to keep going. How would I conceptualize in terms of US, CS, conditional response, and OCD person who fears contamination agrees that the chances of catastrophe are very low, less than 1%, asbestos radiation, but can't live with the guilt that she exposed others to the possibility, however low. So the US is exposing others to the toxin. The CS might be, whatever it is that the feared contaminant that they're bringing into the home. Is it in cleaning products? Is it other things that they're doing it? And the conditional response will be the anxiety and a little bit of the rumination and the perseverative thought, because that's conditional responses are ways to prepare ourselves for the upcoming US. So that's how I would conceptualize it. I think I would wonder whether the fear very low than less than 1% is them trying to think rationally, or kind of really what's in their gut and from their OCD perspective. And, seeing, depending upon the nature of how this is formulated, whether there are testable ways for you to do exposure from this standpoint. An example of the ultimate exposure. So for somebody with panic disorder, it might be exercising really intensely for 15 minutes while out hiking. There aren't a lot of people around. They don't have their cell phone, water, or anxiety medication or anybody with them. And it's warm outside. Maybe that's something that would be like, if that happens, they're going to die. That might be an ultimate exposure. How do you use D-cycloserine? We don't use it on an outpatient basis or in prescribing. It's usually right now just used in terms of clinical trials that are going on. So it's not something that is appropriate at this point in time, really, even though it's not harmful. It's not really used, to my knowledge, although maybe people do, on kind of like an outpatient basis, or if there's a psychiatrist who's prescribing it. Do I ever incorporate the concept of uncertainty into exposure work? From an associative learning perspective, for example, a patient may learn that they are less likely to get sick if touching contaminated objects from exposure practice, but that does not mean that they can say with certainty. So more tolerating the uncertainty when facing feared situations. I think there's always, for many patients with presentations, they're not 100% sure if the bad thing's going to happen or not. And so there is always some toleration of uncertainty. But if there's a testable predictive association, a Pavlovian association, then I focus on that, because that's the main thing that I think is important. And the tolerance of uncertainty, it kind of comes along for the ride, because it's, in my mind, in that case, a less principal mechanism. What is a good first step if the patient has enough insight to seek therapy, but such low insight they refuse to perform serious exposures? Yeah, I mean, this is hard. If they're not willing to do exposures beyond what they're going to do to survive, I think you're really working on motivational work. At the very, this might be a case where you need to do some cognitive restructuring and work on that beforehand. Really basic early exposures that, even if they're low on the extinction learning standpoint, are high in building self-efficacy. So that might be what you might want to do. Counter conditioning fits with this model. Is a great question that we don't have time to go into. I'm sorry. Sounds like the woman who's has some beliefs and maybe really valid beliefs about pregnancy that are worth addressing, and maybe not a focus of this exposure work. And last two questions, I think, if there was a trauma and it's not uncommon with PPOCD, do you ever deal directly with it? If their patients' compulsions now involve their own kids choking, let's say. I still deal directly with the particular Pavlovian association that's present, the memory, the associations about all of that, the thinking about it will decrease as you deal with the sort of in vivo exposure or the predictive Pavlovian associations that are present. And finally, this is probably going to be a hard one, right? If the goal is to test out the prediction, can you address the tricky issue when testing involves repeated doctor visits, HIV tests, et cetera, after each exposure? Unfortunately, I don't think I have enough time to talk about this in depth. Feel free to email me if we can chat elsewhere. And I'm open to, I love chatting about this stuff. So open to talking about this at any other point. I want to thank everybody for your wonderful questions, as well as ADAA for letting me kind of be here and babble about things that are really fun for me. And so thank you, everybody.
Thank you, Dr. Trainer. You made my job easy today, and I think you answered quite a lot of questions and got to a lot of the information. If anyone here today is not an ADA member, we invite you to explore membership to attend continuing education sessions like this, complimentary, an unlimited amount of complimentary CEs. We also invite you to explore our website and reach out to Dr. Trainer with any of the questions that we did not get to, but there weren't very many of them, so way to go.
Thank you, everybody.